This is the One Thing Podcast, and I'm your host, Dr. Adam Rindy. The One Thing Podcast brings together leaders in functional and naturopathic medicine to discuss actionable information that may unlock puzzles in the areas of gut health, brain health, metabolism, and longevity. Please note, these episodes do not replace the opinion of your doctor. They are not intended to diagnose or treat any condition. Please discuss this information with your provider and discuss your own unique personal health history before adapting this information. Please subscribe to our episodes so that you can stay on top of the most current information in these areas of medicine. Receiving a diagnosis like irritable bowel syndrome, otherwise known as IBS, often comes with a stigma. Some have felt that IBS is a diagnosis a doctor would use to describe symptoms when no serious pathology has been found. Thankfully, we've come a long way from this definition, and now we recognize that conditions like IBS involve scientifically proven imbalances in both the gut and brain, and must be treated as such. This progress can largely be attributed to the work of the Rome Foundation and the guests of this episode, Dr. Douglas Drossman and Johannah Ruddy. They are the authors of the new book, Gut Feelings: Disorders of the Gut-Brain Interaction. In this episode, we'll dive into the details of the gut-brain axis and how constructing treatments and approaches to address the biology, psychology, and social aspects of these conditions is needed and is happening today. Please join me in welcoming my special guests, Dr. Douglas Drossman and Johannah Ruddy. Dr. Drossman and Johannah, welcome to the One Thing Podcast. I welcome you for being here with me today.
Thank you.
Thanks for having us.
Yes. So I thought we could, sort of structure this discussion because there's been some changes with functional digestive disorders that have, as far as the classification and understanding. And one of the things I would love to hear about is just a little bit more about how that came to be. If you could talk to us about some of the changes that are taking place with understanding functional digestive disorders and what we are looking towards for the future.
Sure. I'm glad to do that. Well, there's a history to this. If you go back 100 years or more, these symptoms were just considered that symptoms: diarrhea, vomiting, constipation, abdominal pain. And then as the field evolved, we got into gastroenterology becoming an entity, and that was really at the beginning of the 20th century. And what became dominant at that time were what we called structural disorders: ulcers, pancreatitis, Crohn's disease. And people who didn't have that, which was about half the population, had something else that defined a real term, and they started to call it functional. Functional meant that the original intent of functional would be a problem in the functioning of the GI tract. But really what it came down to was they felt that there was nothing that we understood, because the concept was understanding everything as structure. Now, around the mid-20th century, what became popular was motility, and there were people who worked in motility looking at pressures that were generated in the bowel. And they thought that explained these symptoms. Well, actually, it didn't. It did explain diarrhea and constipation, but not as a disease entity. It just explained that the motility was fast with diarrhea and slow with constipation. And then what happened is in the late 1980s, a group of us were thinking that these so-called functional GI disorders, there was more to it than that. And we basically formed an entity that became the Rome Foundation. And this was a bit of a paradigm shift, Adam, because it wasn't based on structure. It was based on, in the absence of structure, were there collections of symptoms that would define an entity that could be properly identified and treated around the world. So we came up with what we call diagnostic criteria. So it's the endoscopy and x-rays are negative, but we can define these cohorts by these use of criteria, which are specific symptoms that we call breed true. So irritable bowel it's the same set of symptoms. It's just like an eating disorder, anorexia nervosa. There's no blood test for it, but you know what it is by the criteria, or any psychiatric condition. So that's how we evolved the functional GI. And then the big change occurred is as the Rome Foundation went through 4 iterations through 1, 2, 3, and 4, just like DSM, we said we got to change the terminology. And the reason we wanted to change the terminology was because people were not giving it due recognition, because it was the absence of structural disease, the absence of a diagnosis that you could find, and it was a grab bag. At the same time, the science of neurogastroenterology was emerging, and we were learning that there are physiologic bases for these symptoms. So what we found is it related to the interaction between the brain and the gut. We call these disorders of gut-brain interaction, and that became our terminology. We changed functional GI to DGBI, disorders of gut-brain interaction. And if you think about it, the brain and the gut are very closely connected. In fact, in the embryo, nerves go to the brain and nerves go to the gut, and they're hardwired. And that's why you can be stressed and have diarrhea. You might see someone get hit by a car and throw up. The connection is so great. And that then led to us coming up with definitions for the disorders of gut-brain act. Motility, visceral hypersensitivity, altered microbiome, immune function or leaky gut, and brain-gut dysregulation.
Yeah. What I really like about the definition in this new classification is it points to the pathophysiology and like some actionable steps that people can be thinking about when encountering a patient, and how to stabilize that patient's digestive tract. So I don't know if that was one of the intentions, but it seems like each of those areas that you talked about, such as the microbiome and visceral hypersensitivity, have therapeutics that target those issues.
That's where we're going. We're going to try to identify meaningful subsets by these criteria and by the physiology that has specific treatment. So someone can have IBS, abdominal pain, and say diarrhea. And as you get to know the patient and you understand their history and their symptom profile, you may learn that one patient had an infection and had what we call post-infection IBS, where they're dealing with alterations in the lining of the sensitivity of the bowel due to the bacteria. Another group may have early trauma, and they may have poor influence by family that might be negative about healthcare seeking, don't go to the doctor, or go to the doctor too much, or being too indulgent on symptoms. And that leads to behaviors later in life where people may go to for instance, if a child has an illness and the parent is overly attentive and keeps bringing them to the doctor, well, the child learns when they have a little ache, they're going to go to the doctor.
Mm-hmm.
And those are the high healthcare utilizers. And the low healthcare utilizers are the ones where they feel ashamed to have the symptoms, and they feel embarrassed. And then there are gender differences. Men are less likely to go than women, because men tend to be less expressive about GI problems or physical symptoms, whereas women might feel more comfortable going.
Yeah.
So all of those things help us determine what's the best one way to treat.
Yep, that makes sense. And so that leads me to my next question. So Johannah, if you could talk about the patient experience and sort of educating them. So like in years past, patients that were given a diagnosis of, say, IBS were almost felt brushed off. It was like, oh, they're just telling me this because they don't really have an answer for me. How has that changed in what you see? Because I know you're really involved with education and helping the patients understand their health.
Mm-hmm. Yeah. So for one thing, the reclassification and the renaming, if you will, from functional GI disorders to disorders of gut-brain interaction is a really big thing for patients, because it's providing more legitimization to these conditions. The word functional tends to have a bit of a stigma attached to it as being not real or not legitimate or psychological in nature. So renaming them as disorders of gut-brain interaction, as you mentioned, brings in the pathophysiology, which then legitimizes the condition, makes the patients feel better about their diagnosis, like, oh, this is a real medical problem. It's not all in my head, which you're right, that had been a problem for a long, long time. Physicians thinking of it as a diagnosis of exclusion, not really giving a clear diagnosis once all the tests show as nothing organic going on and they're negative endoscopies and colonoscopies. So, coming back to the patient saying, well, we didn't find anything, there's nothing wrong with you, so I guess it's IBS. Well, as a patient, when you have this subset of symptoms that are really severe and life-altering, you're missing work, you're missing time with friends and family, you've changed the way you operate to kind of work around your symptoms, that's really disheartening to hear. It must be, I guess that's what it is. And, just eat some yogurt and try some yoga and really lower your stress. You'll be fine. Well, that's not really practical information and not very helpful for most patients. So I think for patients to better understand the pathophysiology of these conditions is key, because then they know that it is a legitimate condition. They know kind of how to handle it. So I talk to patients a lot about, okay, so these are your symptoms, and this is the diagnosis you've been given. It is a real diagnosis, and there are real treatments that we can offer that can really help you manage these symptoms and regain control of your health. What might they look like? It could be lifestyle modification. It could be some dietary things. It could be some over-the-counter medications. For severe cases, talk to your doctor about these different medications that can help with the diarrhea or with the constipation or even with the pain. I talk a lot to patients about the anxiety and the stress that comes along with a chronic illness. And so it's not that the anxiety and the stress is causing the illness, but they're exacerbating your symptoms, because it's stressful to have a chronic illness, particularly one that's GI related, because literally every time you eat or drink, for a lot of people, your stomach hurts or you're in the bathroom. I mean, that's anxiety inducing.
Yeah.
We talk about that. I talk to them a lot about that and how the brain and the gut are connected and how that happens. So, Dr. Drossman and I like to say a lot, when you calm the brain, you calm the gut, and vice versa. And so I use that metaphor a lot to help patients understand that connection, the role that their brain is playing in their gut symptoms. I think for patients to understand all of that, education is really important, because once they have that, they're like, okay, now I feel better in control. I know how to handle this, and I know how to talk to my doctor about it. And it's not something that's controlling me. I'm controlling it. And that's really big thing for patients.
Yeah. Yeah, that makes a lot of sense. And I think it also, I imagine, is helping doctors, maybe not on level of like a gastroenterologist, because, sort of they've been in the trenches with this for a while, but even, other like primary care providers now may have more of a roadmap of what to do. Because like in the past, it's like you have diarrhea, I'm going to give you something to stop it. You have constipation, I'm going to give you something to facilitate having a bowel movement. And that was kind of like, I remember going to a conference and someone said it's a little bit like whale watching. It's just like go one end to the other, looking on what side of the boat you're looking at. And now it's like, okay, well, let's step back and see, how did you get this condition? What is your underlying, what's more of the root cause of what's going on? And there's more, I think, of a chance to not be symptom-based only.
Yeah, but there's more learning for the doctors that are needed too, because it's true in primary care. I remember consulting with pharmaceutical companies in the past, not too long ago, and one of the issues was that the gastroenterologist got it in terms of mechanism, but primary care in just a few minutes, and they said, "What symptom am I treating?" And the companies were trying to say, understand the pathophysiology, that's how these newer drugs are working. So I think there is that. And the other part of the education for the doctors as well is to accept these as real conditions, just like Johanna's telling the patients, because they don't, there's a lot of pressures on doctors now. They have to see more people in less time, reimbursements are dropping, there's more time needed for certification. And only 60% of the time, well, 60% of the time is spent. Let me turn that around. 40% of the clinic visit is face-to-face time with the patient in most cases because of EMR and other things that have to be done. And the doctors tend to gravitate toward the structural abnormalities because they think that's more real. In primary care, if it's a broken foot or pneumonia, or in GI, if it's Crohn's disease, that may get more attention than stomach pain that's been there for a long period of time. And that's where the whole idea of understanding that these are real disorders, understanding what the brain-gut axis is.
Yeah.
That pain is not just the injury that happens at the level of the bowel or the body. It's a combination of the signaling going from there and the brain's ability to downregulate or modify. And that's where the psychologic part comes in. The brain-gut axis, people don't think about it, but it was a major breakthrough. It led to the Nobel Prize in '64. The way it started was that an anesthesiologist in World War II named Henry Beecher was giving pain medication to soldiers in battle. And what he found was the soldiers weren't asking for pain medication. They weren't having pain on the battlefront. And then when they went back to the hospital, pain went up and morphine requirement went up. And he said, there's something different about this. And he figured the brain must be modifying the pain experience because he felt there was a ticket to get back out of the battle. He thought that the soldiers knew they'd get out, or they might have felt they were too worried about getting killed. But anyway, that led to the two psychologists, Melzek and Wall, to talk about this bi-directional system. And when you understand it that way, it opens up the door to hypnosis, to cognitive behavioral therapy, to meditation, to the use of neuromodulators, which actually work on the brain's descending inhibitory system. So if doctors learn that, it makes it more real for patients. And a lot of our effort with the Rome Foundation is to try to teach doctors through our workshops the science behind what they're doing.
Yeah. And, it's interesting because the patients know this, the doctors need to know it. Like the patients know it, that they experience it. If they're getting ready for an interview, they can see their gut symptoms increase. If they're, it's and then the doctors that haven't had the experience of having a brain gut disorder, the education, is what's going to bridge this these two worlds. I think. It's interesting because I think everybody who sits back and realizes this gut sense that we all have, and these kind of gut feelings, like the topic of that we're going to talk about in a little bit, is something we can all relate to, whether you have a digestive disorder or not. And what is that? Is that a neurotransmitter syncing connection? Is it like you're talking about afferent nerves, descending nerves? And I think it's something that the IBS patient experiences almost daily.
Yeah, and I think think about the poor doctor. They go to med school, and what they're taught are biologic sciences and structural abnormalities, and later in residency, they're looking at imaging. But the patient's experience of ill health, we call that the illness, is not adequately taught. And so their whole goal is to find that misdiagnosis. I'll tell you an interesting anecdote. I was giving grand rounds at NYU about 15 years ago when I looked at the residents, and they presented a patient who had abdominal pain IBS type symptoms, was very severe. And the residents were complaining about how annoying it was to have the patient come back over and over again. And they didn't know what to do. And it actually had led to a discussion of their sense of helplessness because they didn't understand these conditions. And then I said to them, if on the next visit you made a diagnosis of pancreatic cancer, would that make a difference? And they actually felt relieved. There was a sense of relief, saying at least we have something to work with. But from the standpoint of the patient would surely die. Whereas with these other conditions, you can live forever. Your life's not affected.
Yeah.
But you just have to learn how to treat them. So there's this whole mindset of finding something we feel comfortable with, what we learned about, which is structural diseases. And once we can get to the point, Adam, where I think there's a cohort effect. I think the younger doctors are getting more familiar with this. But the middle-aged and older doctors want nothing to do with it. And they don't even want to hear about it from pharmaceutical reps or from CME programs and the like.
Yeah, and I think that's certainly true in my community too. And I've co-managed certain patients with gastroenterologists, and I've been really impressed by some of the younger docs having the IBS conversation with me. And what can we do? Whether it's breath testing or can we look at some other biomarkers to help this patient? They're thinking about things like mast cells and histamine issues, and these conversations are happening, and it's exciting for all of us because we can offer the patient actionable steps that they can feel better with. So yeah, and I think also, just to your point with that kind of example you gave, is that people who have anxiety benefit, like you're talking about, from some of these, the relationship, the patient-doctor relationship, and how you sit with the patient, right? And that's when maybe we can go into the gut-directed psychology and some of the hypnotherapy interventions that requires really good patient rapport to be effective, right?
Yeah, well, there are two elements to it. One of the treatment modalities, but the first step before that is the doctor-patient interaction. How can the practicing doctor, who's not a psychologist, help the patient? And it may need referral, but it may not need referral because, I don't know, maybe Johannah could talk about a little bit about what a difference it made if the diagnosis was given to them and the physiology was explained, and the doctor establishing a sense of trust and being available. Do you have any elements you want to bring up, Johannah?
Yeah, I think it's about the relationship that the patient has with the doctor. So first getting a clear diagnosis and then education around what that means. What's the treatment plan going to look like? Being the patient feeling comfortable to ask questions of the doctor that's managing their care. If the treatment plan is not something that they're comfortable with, being comfortable enough to say, I don't know that I want to try a neuromodulator right now. What if I just try, A, B, and C instead, and then come back to that? But it also is if the doctor thinks that gut-directed hypnotherapy or CBT or any of those other treatment modalities are something that would be beneficial, it's making that recommendation to the patient in a way that's not stigmatizing. So the doctor, because a lot of patients, they hear you need to see a psychologist and they immediately interpret that to be, you're telling me I'm crazy or I have a psychological condition. And so it's really about managing that communication and explaining the brain-gut axis and explaining the role of stress and anxiety and all those other emotions on the symptoms. And how that GI health psychologist is going to help manage the symptoms. So they're not going to look at any other psychological conditions that might be comorbid that you may not have. They're only focusing on your gut symptoms and how to help you manage those. And so I think that can be very beneficial for a lot of patients who are willing to give that a try, for sure. But like Doug said, I think, for a lot of us, myself included, it was just about finding that doctor that was willing to invest the time and into a relationship with me, that was a long-term relationship that I felt comfortable with, asking questions and being a part of the team of my management plan.
Yeah. I can see that. And, it's interesting because I think having, every patient has a different, will guide us all with a different modality or direction, right? So some people, they're not ready for interfacing with something that's related to like CBT, or maybe they've had some trauma that they're not ready to confront, but they're willing to talk about nutrition, or maybe get some education on, say, like the low FODMAP diet, and then you can build from there. So the nice thing about what you guys are doing is that you're giving a place for the patient to get deeper treatment and to go into a process, because each IBS there's all of these different subsets, right? So what's true for one person is not going to be true for the next person.
Mm-hmm.
Yeah, and it is a process. It's all about what's called patient-centered care. 2 decades ago, the Institute of Medicine, part of the National Academy, noticed that they called it a chasm between doctor and patient, where doctors were taking control and prescribing and patients were dissatisfied. And they realized that the patient has to participate in the care. And that's not traditional, that's not surgical. It's maybe certain subspecialties like family medicine, psychiatry, and some internal medicine, or other medical fields are getting there. But for the most part, it was doctor-centered. And so this was a big paradigm shift that is still not taken hold, that we propose, that patients make the decision, the doctor provides the options. The doctor is the knowledgeable person where you weigh the benefits and the disadvantages of treatment, and the patient makes the decision. By doing it collaboratively, then there is an advantage for the patient and the doctor. The patient feels more empowered, more able to make decisions, and more responsible. And all the research on chronic illness shows that better outcomes occur when patients feel responsible for their care. It's also better for the doctor because the doctor is, let's say, off the hook of feeling totally responsible for the management. So if you give a patient a treatment and 3 months later they say it's not working, what are you going to do now? Then the doctor tries to figure out what to do next. But if you do it collaboratively and the patient's not doing better in 3 months, then you say to the patient, well, let's look at the other options we talked about. What do you want to do now? Huge paradigm shift. Now, when you get that kind of interaction, you build what we call a nexus or a relationship or a bridge. And then patients are more trusting, more willing to discuss things that they wouldn't normally do before, more willing to hear what the doctor says. And then when the patient does that and they like the doctor tends to like the patient. And then what you have is a collaboration. And then you can get the information you need to decide, should we also be getting CBT or anything else?
Right.
So you have to build that. And that's what the Rome Foundation and my group called Drossman Care are doing. We're running training sessions to teach people how to do this.
Mm-hmm. Yeah. And it's really interesting because, when I run into some resistance with certain patients about talking about the brain-gut connection, I often refer to a paper that I came across where they looked at IBS patients with the various interventions that are available, and mind-body interventions had like a number needed to treat of 4 or something.
Yeah, that's right.
Amazing. 3. Okay, even better than I thought. So, and it's kind of, for certain people who are more data-driven, it's eye-opening.
Yeah, but the pharmacologic drugs could be 6 or 7. The difference, of course, is also the selection. Patients, we did some when we had an NIH grant looking at CBT, and we found that we looked at 240 people, and it was very positive outcome with CBT. And what we found were the strongest predictors was believing that the treatment would work, believing you had the capability to affect a change, and the relationship with the therapist. That came up on top more than the technique.
Okay.
It wasn't what you did, it's how you do it. So with that in mind, the ones who go through CBT or hypnosis are motivated to do it, and they're in a very different position than someone who goes reluctantly or is just given a pill, because they're participating in the treatment. The engagement of the patient in the treatment makes a big difference than just taking a pill.
Yeah. Wow, that's really interesting.
With CBT, I mean, the thing that I love about CBT, I mean, as Doug mentions, the patients have to be an active participant and they have to commit to it. It is a little bit of work, as you probably know. But the thing that I love about it is that it reframes those thought processes that so many patients with chronic illness get of this catastrophizing. Oh my gosh, what if this is going to happen? And then I won't be able to do this. And then what if this? And it just becomes this big, snowball effect. And it reframes all of that into a way that you start thinking, okay, as the patient, if I have an accident while I'm in public, which, by the way, I know cognitively has not happened in over a year. But if it were to happen, I would be okay. I wouldn't have a complete meltdown and never leave my house again because I know I could take these steps, A, B, C, and D. And so it really reframes this kind of catastrophic thinking that can kind of get out of control with patients with bowel issues. Where they suddenly are quitting their jobs and staying home and not socializing and not seeing anyone. And then you lead to this whole social isolation and stigmatization and all of these other comorbid depression and issues. So it helps reframe that whole thing and flips it around. And I love that because patients come back after doing the work of CBT and go, I don't have those same fears anymore. And my symptoms are so much less severe than they used to be. And you kind of go back and go, is that because your brain is now controlling your gut? It's really interesting. I really love the CBT approach for patients.
Yeah, I love that.
You've alluded to the idea of how do you get them to that point because they may not want to go. And if I could provide some tips, I think the first thing is, patients come in with that mind-body dualism. I have this pain. There must be something that's being overlooked. And the first step is to be able to educate, cancer, which is their biggest fear, doesn't become painful until really advanced stages. And most chronic pain is anything but cancer. It's a predictor of not being cancer if it's been around for years. And the focus then is on the management. And if you explain that the brain has the power to downregulate, as I said before, you can then talk about it. And then they say, well, I know it's not stress. I know it's not in my head. It's real in my belly. And then you point out, you can give them examples of how the brain can have that effect and up and down regulating the pain.
Mm-hmm. Yeah, it sounds, you go from like a maladaptive state to being adaptive, it's kind of interesting. I always have experienced personally, but also with patients, like the feeling of being out of control is almost worse than hearing worse news, because when you have a plan with bad news, it's different than having an out of control condition and not having a plan. Mm-hmm. And so what I was basically saying is like you're giving them tools to adapt and have a plan.
Yes.
Yeah. And the idea is that when you talk about illness, there's predisposing, what happened genetically or early life, precipitating what happened that triggered it, and perpetuating it. And many of the patients with chronic illness are in a perpetuation mode. A lot of the illness itself is not as relevant as the way they have changed as a person that's perpetuating. Because now they're hypervigilant. Johannah very nicely talked about the anticipatory anxiety that has to be addressed. So they get a symptom, and I often say to them, what goes on in your head when you get a bad episode? And they'll usually play this tape for me. Oh my God, here it comes again. I'm never going to get better. I have no control about this. I feel so vulnerable. I don't trust that anyone can help me. All of that. And that's tools for CBT.
Mm-hmm.
And the dysphoria, the anxiety, and the depression are tools for neuromodulators. And that's why the combination can be very effective treatments as well. Now, that's the more severe chronic condition. The doctor also has to say which patients go to that and which patients do we give rifaximin or an
Right.
antispasmodic. Because what you're dealing with a brain gut disorder is dysregulated. To what degree do you treat the gut? And to what degree do you treat the pain, the brain, or both? And that's where the discerning clinician can make those judgments. So we do have some people, who are low FODMAP diet or antispasmodics or fiber in some cases might make a big difference. But when it's been going a long time and it's more severe, we have to introduce the brain part of it.
Makes sense. And then also, they're not living in a silo here with just IBS. A lot of patients have other related or non-related conditions. And I'm even, seeing more and more that there's an acceptance now that IBD patients, like 30% or so, also have IBS. And so, it's something that, it's really good to have this structure, but also to realize, like you're saying, that what people are able to do, really depends on the totality of what they're experiencing. So I'd love to spend the rest of our visit together hearing about gut feelings. It's, I know it's launching soon, and you guys are really excited about it. I'd love to hear just more about it. I know we've touched upon some of the topics that are in the book, but can you share more about gut feelings and what you're hoping it does for the community of doctors and patients?
Yeah, well, it's a collaboration. I'll start because I always like to jump into these things, but I don't know. We want her input as well. So, my whole career has been teaching doctors and even doing communication skills work up to doctors about how they can improve their communication with patients. And been doing it for a long time. But what really happened was about 3 years ago, I met Johannah, and that made a difference because she, as a patient and a patient advocate, was giving a perspective to me that I was learning from too. And then we also found out, she won't acknowledge this, but she's a very good actor. So we started doing videos where she did role plays of patients that mimicked all these conditions of patients I've treated for 40 years. And so we started doing these workshops, and it just grew and grew. And then somewhere along the way, we decided we also should be doing these for patients. And then it became clear, why not write a book for patients and doctors? And it really came out as good as I could have imagined, because I had to work on making sure the language was clear enough for someone who was, let's say, high school educated, not a medical degree. And Johannah had to work toward saying the things that would impact on doctors. So that's my side of it. Maybe you want to add your component.
Yeah, well, it's pretty good. I will say that COVID gave us this opportunity. We had talked about doing it maybe a year and a half ago, but with the load of work that we were carrying with Rome Foundation, it was like, yeah, maybe someday that would be a really cool idea. And we were talking more about doing things for patients to help patients better understand these conditions as well. That's something that I'm still really passionate about doing. So this is the first step of hopefully other programs. But then COVID came and all of our travel ended and all of our big conferences were canceled. And we were like, well, maybe we should write that book we've been talking about. And so it really was a nice opportunity for us to collaborate on this. And as Doug mentioned, we each have our own roles in it. But I think for patients, it's going to be really enlightening for them. You mentioned at the beginning of this conversation that your patient audience likes to hear some of the science behind these conditions, and they want to know what's going on inside their bodies. And that's exactly what this book does. It talks about, why these conditions were considered functional or psychiatric early on and why that's not true. Then it goes through every single condition and it explains the pathophysiology of it, the medication options, and the mechanism of action of all of the treatment options. I mean, it's really well done, scientific, data-driven, but in a way that patients can understand. We have great, beautiful illustrations and images to help patients see, internally what's going on inside their body. And then we move into the patient's role. Patients have a responsibility in managing their own health. It doesn't all fall onto the doctor. And so we really I talk about what the patient's role is, how they should expect to be treated with respect, with dignity, etc., but what their role is as well, and what they need to be doing to help manage their own care, how to advocate for themselves, all of those sorts of things. I tell my story, which I go into a lot of personal detail with, so hopefully it doesn't turn people off. But I felt like it was important for people to understand where I'm coming from as a patient as well. And then we talk a lot about other issues related to patient care, how women are treated differently than men when it comes to pain management, kind of that disparity that still exists in the healthcare system with managing women's healthcare. And we give some examples and some data around that. And then I talk a lot about stigma and shame and how that can affect a patient's ability to heal and manage their care, and why we should ditch it. I say ditch the shame. These are conditions that are very, very common. Lots of people have them, and the more we talk about it, the less stigma will be attached to it and the less shame will be attached. So let's start talking about it. And what that can mean for patients and empowering them to have those conversations. So all in all, I think, I hope that it's a great resource for patients, but I hope it also helps doctors to better understand how patients are thinking and feeling about these conditions and how they can better manage their patients' care.
Yeah, that's so great. I mean, a vehicle for communication, it's a kind of a playbook for understanding options. And, I think the way that patients are coming with information to their doctors already, and to have something that the doctors can see has been well researched and well put together and is well thought through, will be more likely to be accepted as being, okay, let's do this, or I'm going to pick up the book myself as a physician and read about it and learn more. I know the gastroenterologists are overloaded with IBS patients, and they can't really manage other conditions as much as they need to because of the demand. And so I know that there's going to be more providers needing to learn about IBS and disorders of gut-brain interactions that are not gastroenterologists, primary care doctors, nurse practitioners, et cetera. So, I appreciate your time. This has been really helpful and informative, and I would love to hear if you could either of you or both of you give us a few take-home messages just to kind of finish up with, and then anything else you want to share about how we can follow your work. I will be putting links to the pre-sale of Gut Feelings in the show notes.
The first thing is buy the book. It talks about everything we said, and it'll be available, and you can get it from the Rome Foundation website as well. But I think the take-home messages for doctors is to understand the science behind these disorders, to make it real for them, and to understand the basics of communication, which is in the book and in a lot of our programs, the workshops and the articles we published. So you can search Johannah's name and my name to learn how to develop a patient-centered care model where the patient likes you and you like them. It brings more meaningfulness to the practice. If you understand the science and you develop the relationship, you'll be very, very satisfied. So that's my take-home message to the doctors.
Yeah, and I think for patients, patients with chronic illness just need to remember that chronic illness is just that, it's chronic. So there's not going to be a magic wand or a magic pill that's going to completely bring about total recovery and healing in one fell swoop. So be patient. But the more you understand about your condition and about the treatments and the role that you have as a patient to manage your care and advocate for yourself, then the closer you're going to get to a more normal quality of life and back to kind of the life that you might remember before all of these symptoms kind of started to take over your life. And I think, continuing to be hopeful and not hopeless is a really important thing, because chronic illness can kind of start to be draining sometimes and leave you feeling hopeless. But keeping that hope that little steps forward are going to bring about big change in the end is really important. And you can follow me on Twitter. It's at Johannah Ruddy. And I talk a lot about education for patients with these conditions. I actually work with a lot of doctors in doing some education with them as well. And then we have a platform for patients and clinicians on Twitter called Tuesday Night IBS. So at Tuesday Night IBS, every Tuesday night at 7, we come on and we do live chats. We have a lot of patients that share their concerns and their questions and their symptoms. And then we have a lot of docs that follow us and give recommendations and ideas, nutritionists and gut-directed hypnosis and all sorts of things that we talk about. So I'd encourage you to follow both myself and the Tuesday Night IBS on Twitter as well for additional resources.
And then the Drossmancare.com is the educational program, and the practice itself is for more complex patients. And we have educational workshops and things of that sort. And then we both work with the Rome Foundation, which is the romefoundation.org.
Excellent. Well, great. Well, thank you so much for your time. It was really nice connecting with both of you.
Thank you. Appreciate it.
Thank you so much for tuning in to this week's episode of the One Thing Podcast. Please share these episodes with your friends, loved ones, colleagues, patients, healthcare providers, anyone who you feel might benefit from hearing these informative interviews. We tend to learn best from people sharing things with us. That's often the first time it's introduced. So don't hesitate if the content of these episodes reminded you of someone that might benefit from it. Forward the episode to them, and I'm sure they'll either appreciate it or be appreciative that you've thought of them. So once again, we'll look forward to seeing you next episode on the One Thing Podcast. And again, much appreciation for you being here with me.